Okay, and we are live. Welcome to the November 2020 Certification Coaching Q&A webinar. I
Hi,
am your
everybody.
host, Jesus Perez, and here is also Jennifer Sanders and Alicia Scott. Say hi, everybody.
Hello.
New format. Woo!
We're testing out a brand new format. We used to use GoToWebinar, but now we are trying out this new platform called StreamYard that lets us really interact with the community and really just like show so much more quality information to you guys. So real quick, just want to kind of cover some stuff here. So I'm going to get this kind of rolling. I am going to move on to the first slide. I want to make sure that everybody here can hear us. If you guys can hear us okay, please type a 1 in the chat. And if you cannot hear us, type a 2. And if you can't hear us and you're typing 2, you might want to restart your browser. Maybe. Hello, I can see the questions coming in. I can see the comments. I can see all kinds of people saying stuff here. Hey, Diane, how you doing? Hello, Nancy.
I see names I recognize.
Chrissy. Everyone, I see tons of ones. So it sounds like we are actually being heard, which is great.
Mm-hmm.
Okay, so if this is your first time attending, welcome to the CCO community. This is our monthly Q&A webinar chat. Just in general, this is a general webinar about all the things related to medical business certification, medical billing, medical coding, auditing, practice management sometimes, risk adjustment, auditing, all that stuff is discussed. We take all the questions from our topic requests inside of the CCO Club community, and we convert them into presentation topics during this event for you guys to learn and eventually see transcripts and replays inside the CCO Club. So you're probably noticing that I'm not Boyd, and I'm not. I'm different. Boyd has decided to leave CCO. We miss him dearly, and we wish him the very best of luck. Since 2012, Boyd's incredible video production and presentation skills have helped shape and energize CCO's reputation in the marketplace. He's going to be sorely missed, and he has our very best wishes for success in his video production business. You can find him at Changing Productions if you want to reach out to him. And we just wanted to take a moment during this webinar to thank him for everything he's done for us over the years. I'm going to be doing some of the hosting, so you're going to be seeing me a bit, along with, of course, Jennifer and Alicia and anybody else who wants to come on.
Yeah.
Now, I did want to cover a slight change to the format this month. Polling has changed. Before, you used to see polls instantly on the screen because that was a really cool GoToWebinar feature. We don't have that anymore, so it's not instant. So we're going to show you polls along with links. And then when you jump out to those links, you answer them. And then later at the end of the webinar, I'm going to show you all the results to those polls at once. And we're going to talk about them briefly. So don't worry, because the first poll is coming up, and this is your first chance to answer it. So if you have a chance, I'm going to go ahead and paste this link inside of the chat right now for everyone. Jump over to the link that I'm pasting into the chat and just answer this question. How many CCO webinars have you attended? We're curious to know.
And I saw that Skylar said hello, and some of you guys remember Skylar, but notice he's now Dr. Skylar because he got his doctorate. Isn't that awesome?
I saw that on LinkedIn because
I remember
I'm
when he did
friends
that.
with him on LinkedIn, and I was like, what? Wait a minute, when did he get that?
I knew he was working on it, and I remember a month or so, that month that he got it done, and he said, I'm done with school. So congratulations, Skylar.
Congratulations, Skylar. Fantastic.
His name pop up.
All right, so now go ahead and go back to that poll and just answer it. If you haven't answered it yet, go back up into the chat and click on that link and answer it when you get a chance. We're going to come back to all those answers and show them to you at the end of the webinar. But I just wanted to talk about the agenda tonight and what you can expect. This is about a 90 to 120 minute webinar. And the reason it is because it's broken down into 3 parts. The first part, which you're kind of experiencing right now, is the introduction. We kind of talk about news, recent graduates, and whatever's going on at CCO. We then transition into the second part, which is the actual Q&A from the community. And that's where we pulled questions and everything from inside the community, and we're answering them for you guys. It's going to be 3 questions from Jennifer, which you can see on screen. There's going to be 3 questions from Alicia, which you can also see on screen. And then the third and final part of this webinar, which is the part that you should absolutely stick around for, is our contest. We are giving away your choice of 1 Review Blitz, 1 year of CCO Club Basic, or 1 hour phone call with Alicia to pick her brain, because Alicia's got all the answers.
And we've got a new format for drawing. It's going to be a lot of fun. So
you're going to love it. You're going to love it. It's crazy. You're going to love it. You have to stick around just for that. So,
really cool.
so do that, okay? Now, so that's what the format's like, and that's why it's 120 minutes possibly, because it's 30 minutes and 60 minutes of presentation, then 30 minutes answering questions from the chat, and also doing the actual live drawing from the contest. So that's kind of like what you can expect there. Now, about the questions in the chat itself, we can see all the questions coming up live, but it's kind of hard to actually read off answers and stuff and actually answer questions also. So we answer them at the end. So ask your questions inside the chat. And at the very end of this presentation, we have 30 minutes dedicated to bring up questions that we can actually answer, because we can't answer everything. Some questions require too much research. They might be too time consuming. They might be too long. And some of them might be too personal, and we don't want to get too personal and divulge private information to the entire YouTube and Facebook community. If we can't answer your question, please go to cco.community. That is where we have everything. That's our life. All the content is there. All of our discussions are there. CCO Club is there. And you can ask
CEUs
questions.
are there. Someone asked about CEUs. They say, so
we're going to be talking about that a bit in a few minutes as well. And if you have any technical questions about access or billing or just private stuff, go ahead and jump over to the help desk, helpdesk.cco.us. Sylvia and Lori will be happy to answer you guys and get your questions I picked up over there, okay? So that's just really quick. Now, we mentioned this briefly, but the reason you want to stay to the end is because we have a giveaway. You have to be here live to get it entered into that giveaway. You have to actually enter yourself. Before, we used to be able to use GoToWebinar to just pull the list of attendees. We can't do that anymore. You guys enter, and then we're going to show you who the winner is live on the actual show. So you can win a CPC Review Blitz bundle or any Review Blitz that you like, that you pick. You can pick one of those, or you can get the 1 hour phone call with Alicia, or you can get 1 year of CCO Club Basic. So stick around until the end. And
you
Alicia,
have to be here to win, right? You have to
be here.
Still be here.
Because not only do you have to be here, there's a form you have to fill out that we can't do that for you. So legally, we can't. We can't. So we get in trouble. Alicia, this is you. Please tell them about the CCO Club.
I saw in the comments somebody said several people are disappointed that we don't give CEUs out for these webinars anymore, and we understand. We did CEUs for a very, very long time, and it was a lot of content for the CEUs, so it was a lot of value in there. But what we did was we changed the format a year or so ago, and actually it saves a lot of money, because the behind the scenes in doing what we did before was it wasn't very cost effective. So now all of our CEUs are bundled into the club. So this content that we give out to you in our monthly webinar, which is the second to the last Thursday of every month, and throughout the week, all of this content we're giving to you free. However, if you want CEUs that are associated to this content, then you can go to the cco.us/club. In the club, you'll have access to the CEUs, you'll have the transcripts, you'll have the answer sheets that you see that we'll be talking about, as well as during the week, the slide decks that we use. All of that is packaged together. And then on top of that, we decided that we wanted to give you more value. So instead of paying for one CEU at a time, we bundled them. So you get 3 CEUs, 6, 10 CEUs, maybe 12 in a package deal, but you don't have to pay more for that. You get to pay the monthly fee for the CCO Club, and then if you're done with your CEUs, you can leave the club if you so choose to, which we hope you don't, but just continue to stay in the club for that monthly fee. And whenever you need CEUs, you have access to everything. So again, this is more value for you, and it's more cost effective for us, because it doesn't mean that we have to pay as much overhead for that behind the scenes stuff. And again, that means you get a lot of free content. And so we hope that if you have any more questions about the CCO Club, it's really easy to ask, or go straight to cco.us/club and get information. Your questions can be answered probably there, or ask somebody else that's in the club, because there's a lot of people here tonight that are in the club.
And the great part about that page is that when you jump over to that page and you look at the very top of the screen, it'll tell you exactly how many CEUs are inside the club right now. And so check it out. Now, the one thing that's cool about the club is that it includes the Batcave, and the Batcave, the Batcave is now also inside of FindACode to a degree. We have FindACode available with a discount if you purchase through the link that you see on screen. Alicia's going to talk a bit more about that and about how we've included Bat inside of the FindACode.
Well, I have an example of it tonight on my answer sheets, because some of the codes that we were going to be talking about in one of the questions was CPT codes, and I actually pulled the bat icon that FindACode uses and show you exactly what it looks like in FindACode, and then you can take that and replicate that into your manual so that you go and test. FindACode's been really, really great to work with. Whenever we have talked to them and asked them, hey, can you do this? Or, by the way, we would like to see this. They do it, and sometimes come up with even better ideas than what we came up with. One of the reasons that I really enjoy FindACode from the beginning, and I found out about them way back when I started working with Lorene and CCO, is that their background is in education. And since we do education full time, it's a very good relationship. It's kind of like a perfect little marriage there. And that if you're wanting to find an encoder that has that behind them, that's their goal, is to help educate you, not just give you information, but the education process, I think that you'll really appreciate FindACode. So if you want more information about them, go to cco.us/FindACode, and got some great examples tonight of how the BAT technique works, and you can get a discount when you use that link.
You sure do. You get a 5% off all the plans with the link that you're seeing on screen. And it looks like even Skylar's recommending this. Skylar said FindACode is a great platform. I use that in addition to the platform in which my employer provides. So thanks for letting us know about that, Skylar. Appreciate it.
Yep.
Now, we're going to move on. Oh, sorry. Go ahead.
No, I just said it's great.
It's fantastic. So we have the second poll up. And I'm going to go ahead and put this in the chat. Go ahead and answer this poll real quick. We want to know, what is your status in the medical business related job world? And there's a couple of options there that you can pick from, but we're curious to know. You should see that link coming up now inside of your chat. So just jump over there and answer that question. And then later on this evening, I'll jump back and show all the results to these polls. Now, we are moving on to our CCO recent graduates. We've had quite a few people graduate since the last time we did this. In fact, we have August, September, and October. So we're going to run through these. And to do that, we're going to start it off. I think, Jennifer, you can kick it off with August.
Sure. Okay. Sorry, mine's over on the side. It's not that I don't want to talk to you, but I gotta see the names. We have Padma Patel, who passed the CPC using some of the various resources. All these people on this page use the BAT method. Jamie Cole passed the CPC. Angela passed the CRC. Gina passed the CPC, and Nancy, I saw your name come up very first. You passed the CPCO. That's wonderful. Very good, the compliance course. So very good.
Okay, and then we're moving on now to September. Alicia, you want to take over with that one?
Looks like Viviana Beltran, she passed the CPC. Zora Bainbridge, CPC. Sandra Shong did the CPMA. Kimberly Gibson did the CPC. Another, two more CPMAs. Yurika Ramirez and Carrie Watson, both. And is it Jocelyn Myram, the CPC? Look at all the BAT techniques that's really helpful, isn't it?
Yeah.
Fantastic. And then moving on to October, we have Brandon Dumlao, got the CRC and the CPCO. So
Yay!
congratulations.
Yeah.
Monfiel P got the CPC. Joe Ellen Ensley got the CPC. Rebecca Castillo got the CPC. Lisa Rubalcado Smith got COC. And Virginia Clavier got the CPC. So congratulations to everybody. Those are some huge accomplishments. And as the year comes down to the end, it's nice to know that you've got those certifications tucked away and done.
That's right.
So
even did it through COVID. Woo!
Well, and that's interesting to see how many people were not the CPC, because the CPC is the only one they can do online. So that means people were able to find a chapter hosting an exam, which is pretty difficult right now. You know, we have to locate a hotel or a church or some kind of facility, because most times we used a school or a hospital, which we're not able to use right now as a chapter. So it becomes a larger expense for the chapter as well, because as you know, you only pay for the exam. The chapter has to pay for the venue. So it becomes that's where some of the difficulty lies in finding a place, getting people who aren't worried about COVID to proctor, and then actually taking all the precautions to host the event as well. So it comes to some difficult times right now. So that's very good that all those people were able to pass and had all that extra time to study since March, I guess.
And we should also, before we get started, let's all give a lovely golf clap to Jesus's beautiful accent. Oh, that was fun in pronouncing all those names.
Thank you. Thank you very much. Okay. So we are starting up with the main presentation now. This is where we start actually answering the meaty questions that we get inside the topic request inside the CCO Club community area. And to start this off, we have Jennifer. Jennifer is going to be presenting this topic on revenue cycle careers. And I'm going to go ahead and show your screen. So you have your screen showing. And I'm going to disappear from the side, and so is Alicia. We'll be back in a few.
All right. So we had a question come in. They're curious about gearing into coordinating coding abilities into the revenue cycle perspective to enhance career opportunities. So researching what employers are requesting. So this person submitted what one job announcement looked like. They're requesting what their candidate should bring in to the table to bring to the business. So the question is, how can that be achieved realistically? How can all these things be done? And what kind of education is it going to require in order to perform a typical job that's based off of the revenue cycle? So let's go into a little bit of terminology here, the revenue cycle. So if you don't deal at all with the administrative side, then you may not, okay, what's revenue? The revenue cycle is what happens from that very first phone call, when either they walk into the ER facility or urgent care center, or they call and make an appointment at an office. So that very first encounter that happens until that final balance is paid, until whatever procedure they had done or whatever visit they had done, and if they're never coming back again. So from the time they very first start, which is usually a phone call, until that very final bill is paid, that entire thing is called the revenue cycle. So managing that cycle is only a portion of what a coder handles, or a CPC, because it's a collaboration of data entry. Because if that's not correct from that front desk person or the receptionist or online, however it's performed, then you're going to have problems along every other aspect of that cycle. CDI, your documentation, coding, of course, getting the correct codes in there. Billing, which is looking at once that payment comes in, now was it paid properly and processed properly? And then, of course, there's always management involved in this as well. Reports and making sure the collections are followed up, and all different aspects of the administrative back-end side. So the whole thing takes a lot of people. So it may sound like, how can I do that one job? So how does this fit, or how does all of this fit into a job description? So like I said, the person listed a job description. So breaking down this description, I'm going to figure out how somebody could break into revenue cycle management, or design the skills required to perform revenue cycle management. And as Alicia says, this is my gig. She hates this. So this is not necessarily billing. It's more involved than billing, but this is where a lot of the billing aspect comes in. So in the job description are the very first bullet points. So they coordinate, schedule, and perform reviews of professional services and documentation performed by providers. They're going to evaluate that clinical documentation to identify inconsistencies or improvement opportunities that could impact the reimbursement, the revenue integrity, and or reduce denials. So what they're looking at is how is all of this documented versus what we submitted, and where are any problems we're having? Are we always undercoding? Are we always overcoding? Are we always forgetting that one service or that medication? We never bill it. Is there discrepancies in there? Old codes, maybe the program is not recognizing a new ICD-10 code or something like that. So that's kind of reviewing everything and looking at it. So typically a CPMA, because you're reviewing medical records, so somebody with auditing experience is usually pretty good. A seasoned CPC or a CDEO or somebody with CDI, so that documentation, being able to look at documentation and see what's required, because documentation is not just that medical necessity that that a CPMA might look at. They're looking at all aspects of the documentation from the clinical staff. What are they putting in? You know, a lot of information going in there. So somebody with those types of credentials could be a good candidate to review the documentation for the providers in a business or in a facility. Of course, experience with instruction, because then you're going to need to educate people on those documentation errors. And a CPB, somebody with that certification, may be a good candidate to understand that reimbursement and that revenue process, because if there's denials, we need to understand what's going on that generated that denial. What step of the process went wrong, or is it a contract issue? Is it an insurance carrier issue? Is it a billing issue? So a lot of different things that are learned in that CPB program. Another job requirement was reviews charge information submitted by those certified coders. So this organization uses certified coders, claim forms, and the insurance correspondence to determine if that coding, the billing, the follow-up, the payments that were received, and if all of that is being performed in an accurate and timely manner. So we can get a claim paid, but is it taking 10 days to get paid like Medicare and TRICARE do? Maybe some Blue Cross plans? Or is it taking 45 days, 90 days? Did it keep getting resubmitted? Was there an authorization problem? So every little step of the way, we could get a claim paid. Is it being paid timely? And is it being paid accurately? So based on that documentation of what's listed. So that's what we're looking at. You have prospective coding and then retrospective coding. So prospective is looking at it before, sending out a claim. Retrospective, you're looking at it afterwards and going, okay, does the code that we sent, does it match that documentation? Because maybe sometimes they tell you a provider, maybe the EHR system generates a code and the coders are just making sure that a modifier is available, or that the code matches the diagnosis possibly. Or is it the doctor said I performed this service, but their medical record's not available for another 48 to 72 hours. So you bill it out, but then we don't have that record to match it up for another 2 or 3 days. So on the back end, you can say, okay, now let me compare all this information. So you take the medical record, you take the claim form that you submitted, you take that explanation of benefits from the insurance, their payment, put it all together. Does it all match up? So that is a CPC with the CPB, knowing what kind of information, about that payment, about claim follow-up. Credit processing, is an overpayment? Is there a refund due somewhere? Are we not paid enough? Knowing that information comes from that certification. So they'd be a good candidate to be able to review all that information. Plus, knowing Excel makes this really beneficial. So knowing those spreadsheets and how to operate them and input money and read some of those reports that might be generated. Another job requirement was preparing written reports of audit findings for internal leadership, clinical leadership, and providers. So any certification, really, you should be able to do this, but you're going to need some experience with Word and Excel. So again, you're dealing with reports, and then if you have to make some kind of letters, make some kind of audit summary, that information you would need to know how to use your Word format, whether you're inputting charts or graphs, not just typing, but all of the special functions that a Word program or Google or whatever kind of word processing program is able to do. Another job requirement is develops educational presentations, learning tools, and training material. That sounds pretty cool to me. I like that. But provides education for both providers and coders for the appropriate CPT, ICD-10, and modifiers based on that documentation and the EMR charge. So whatever is captured in the EMR, comparing all that, is it adding up? So a CPC can definitely understand the procedures and the diagnosis codes. We've hopefully had good enough training that we can understand what needs to come together. You need to be able to research and instruct. So a little bit of that teaching. We'll get into that in a minute. And of course, again, experience with PowerPoint now. You might have to give a presentation. You might have to compile a manual or something. So again, Word would be something to know, but also PowerPoint. If you have to stand up there and give a 10-minute presentation to a provider, well, we need to understand their time's limited. It needs to be precise. It needs to be to the point. It needs to draw their attention and make them understand it and recognize it. Another requirement was serving as a liaison or a point of contact from the clinical coding inquiries and communication from the professional billing revenue cycle. So you're that in-between person. You're that one that might be helping with the queries. You're contacting the clinical staff and how is this process going? What do you guys do? Let's understand how then the coding comes out. Seeks to establish collaborative relationships with physician leaders, clinical providers, corporate compliance, administration, in support of coding education and documentation adequacy. Everybody needs to be involved in this, especially when you throw in there some of that compliance. So they are going to set the rules. Well, we need coding rules. We need, how is everybody going to work together? Are the physicians going to bill for finger fractures or are they going to bill office visits? Getting some input from physicians, from the clinical staff. So CPC or CPB would be a good candidate because they understand that revenue cycle and support the coding and documentation accuracy. So a CPC should be able to look at a medical record or an operative note and be able to extract the information from that. And if you had any kind of management or team experience, that would be helpful in this end. Few last bullet points are assist with claims denial reports to ensure we're getting our optimal reimbursement. Analyzing these billing trends to identify areas of non-compliance. So you have that one provider who's always overcoding or something like that. Assist in the development of corrective action plans. Okay, what are we going to do about that person who's continually billing this wrong? Is it a coder? Is it the provider? Is it the program? Is it the EMR program? Do we need to talk to the IT staff? Do we need to choose a new program or talk to the representative to change a function of the program perhaps? So any CPB, a CPC, or the CDEO, somebody with that documentation expertise are good candidates to look at that compliance with billing standards and address how to make changes. And of course, again, Excel is a good because you're going to have reports and formats and, try and group things together, and Excel is good for that. Finally, we have manages special projects individually or in collaboration with other departments. So really, you don't really need a credential for that, but experience with some kind of management or team supervision perhaps is very beneficial. So are all these skills able to be performed or acquired by one person? Yes. Education and knowledge. So even if you're just received your CPC, if you've been doing this for 15 years, you've been around the industry long enough to understand, but you just, finally decided, well, I better get certified, or my employer's saying I have to be certified. But if you've been around the industry long enough, you've heard these terms, you probably have a good understanding of what compliance is. All those compliance laws, HIPAA, Stark, all of those laws are covered in a basic CPC course as well. They're covered in CPB, they're covered in CDEO, they're covered in CPCO. All of those certifications through AAPC cover all of those healthcare laws, and even some AHIMA, your credentials as well. You're going to cover those healthcare laws. So education and knowledge are very important. If you have a lot of years experience, you could be even a newly certified. Through how many types of educational paths can you acquire these skills? Well, if you're a CPC already, or if you're one of the other credentials, then a CPC is definitely good to have, because it has the basic understanding of all the CPT codes, the ICD-10, HCPCS, kind of how they all work together, medical necessity, how to perform a query, things like that. A CPB, revenue cycle, I would say a good over half portion of revenue cycle is gained through either your vast knowledge and experience in the administrative department or through the CPB. So we cover all those insurances, contracts, participating, non-participating, referrals, collections, aging reports, all of that information, the claim forms, all of that information is reviewed with the CPB certification. A CPMA, CDEO, CDI, some kind of clinical experience would be beneficial. Is it necessary? I don't think it'd be extremely necessary. I think you could handle it with a CPC and possibly a CPB. Definitely this Microsoft Office suites. If you don't have a lot of experience with Microsoft, there are YouTube videos. There are community colleges that offer these skills. You could go for a day course, and of course now they're doing them online, so it might make it even easier to attend one of these. The AAPC Knowledge Center offers a lot of these soft skills. It's really interesting what they offer on their website as well. But time management, leadership. Okay, how do you handle a sticky situation with the conflict between employees? That's something that a leadership is going to handle. Team dynamics, how do I work as a team? All of these skills can be learned. You don't need a degree in them. So if you worked at, Arby's for many years and you became assistant manager, you know how to deal with other people, you know how to deal with a team, you know how to interact with people properly, you know how to deal with professionals. You have an angry customer or you have your boss, you know how to deal or interact with people. So another thing that we mentioned, the teaching or instruction experience. So you don't have to be a teacher or have that certified instructor program, but do you ever volunteer with Girl Scouts or Cub Scouts, Boy Scouts, whatever they're called now, Scouts, help at the school, your child's school perhaps? Do you speak at your local chapters? If there's you don't have to be an expert, or is there something that you're interested in and you offered to present? So just having, there's speaking clubs out there, as are Toastmasters, if they still have that around, being able to present doesn't require a degree either. It just requires confidence and practice. So there are some things that can be learned. So somebody looking in the revenue cycle, I think if you have a CPC currently, you understand the medical necessity portion of looking through these records and the portion of the revenue cycle, but then the CPB would be beneficial to obtain some of those skills. If you have plenty of years of experience, then I would think you should hopefully have some of those skills as well, if you've kind of been around the office long enough and heard a lot of these terms.
Okay, fantastic. And I have to actually echo on some of those last points you made, that having knowledge with Zoom and having knowledge with just remote presentations in general has become a brand new skill set. And some of the Toastmasters and some of these different websites out there that let people come together and speak will let you practice that, because nowadays you're going to be doing a lot of communication over video, and it's good to have that set up also for your resume. So thank you so much for that excellent presentation. Let me go ahead and bring up the next slide here, which is a poll. We want to know, what is your medical background? So I'm going to go ahead and put this link inside of the comments for you guys to answer. We have been getting responses to the other polls. So at the very end, I'm going to show those off and you can see how everybody responded to them. But we want to know, what is your medical background? Now, I'm going to go ahead and turn off your camera now, Jennifer, and I'm going to bring up Alicia. Alicia, you're going to be up next. She's going to be presenting a topic on end-stage renal disease coding. And the floor is yours, Alicia.
All right. End-stage renal disease. You know what? There is a huge correlation between hypertension and CKD. And that's one of the first things that you learn when you start a coding career or you start in school. They talk about these causal relationships. And CKD and hypertension, CKD is chronic kidney disease, are diagnoses that are pretty prevalent, especially in our older population. So it behooves you to know as much as you can about those particular two diagnoses. The question had come in, it said, what's the difference in CKD and ESRD? Why is there an HCC for ESRD? I noticed this in the CCO risk adjustment course, and I did know if this is something I need to know for the CRC. Do I need to share my screen, Jesus? There it goes. Okay. Well, let's start with, what is the code for CKD? It's N18.3, and then this year they added an additional character that allows for further specificity for type A or type B, but the basic code is N18.3, and that would be stage 3 CKD, the more common stage of CKD. This is when it starts to risk adjust too. Now you'll notice that I talk about risk adjustment a lot because that's my background and what I like. And it is very prevalent when you're talking about that causal relationship that I mentioned earlier. So CKD is known as chronic kidney disease, and it's kind of an umbrella. There's several stages that fall underneath that, which I'm going to show you. And then as it progresses into a higher stage or more severity, then it develops into end-stage renal disease. The way they determine what stage a person has of CKD, it's through this particular blood level that I'm going to show you. But know that a person can have kidney disease that is just the kidneys wearing out. It could be something that's genetic, but it could also be attributed to another diagnosis, especially diabetes. Diabetes is very hard on all the organs in the body, especially the kidneys. And they could have just a past of recurrent kidney infections again and again and again, which wears out the organ of the kidneys. That particular blood test that I was telling you about is the GFR. This is the glomerular filtration rate, and that is what you'll see in blood tests, that if that GFR is off, then they know the kidneys are struggling. And if you have done any study with sepsis, for example, or other types of maybe even trauma to the body, you know, if maybe you've watched TV shows or medical scenarios and movies and they say, oh, the kidneys are starting to fail, it's not a good sign. And what they're talking about is that GFR is changing, and the kidneys, you know, when the body starts struggling, the kidneys are one of the first things to go to show that there's a problem. There are up to 5 stages for CKD. Now, the first stage of CKD, and again, the code is N18 for CKD, stage 1, it's very easy to code these. In fact, I would say after learning hypertension, I10 or I10, that's usually the first code people learn in ICD. The next is probably CKD because it's really easy. N1 8.1 for stage 1. And then it tells you this is the GFR, which is going to be based on the blood showing that we have a marker for stage 1. And then stage 2, really easy, N1 8.2. And again, notice that the GFR is changing. Stage 3, once they reach stage 3, this is where you're going to start seeing other complications possibly in the body. This is where you'll start seeing things like hypertension being associated. There's a causal relationship. So if a person has CKD3, they probably have high blood pressure. If they have chronic high blood pressure, they probably have some type of a kidney issue. If they have, again, chronic high blood pressure. Real easy, CKD 3 N183. Notice I put the dash after that, and that's to tell you there's additional characters now for CKD3. 4, easy, N184. Now we get into stage 5. This is where we're getting into severity, where it's classified as end-stage renal disease. There are actually 2 separate codes for end-stage renal disease. You can either code it as stage 5, which is N18.5, or it's coded N18.6. Now, we don't get to make that decision. The provider makes the decision and we translate it. So if the documentation states that the patient has CKD 5, then we're going to code N18.5. If they state that the patient has ESRD, end-stage renal disease, it's N18.6. But there's actually a dividing line there. Technically, what happens is the person has N18.5, but once they start treatment like dialysis, then they end up classifying them as ESRD, which is N18.6. Never make an assumption that it's one or the other. You have to go by what the documentation states. But again, if you are aware that once they're on dialysis, you're probably not going to be coding N18.5 anymore. It's now N18.6 or ESRD. And why is it important to have that tracked? Because of statistical purposes. And I say this almost every time that you hear me talk, that we code for statistical purposes. It just happens to be a convenient way to get paid. So if that differentiation mark is whether the person has started dialysis or not, as well as what their GFR is, then again, it helps us understand why the statistics make a difference and treatments that have to be done. Now, also mentioned by the person that asked this question, which is a really good question, and I'm glad that they paid attention in the risk adjustment course. When you look at a particular code that carries an HCC for risk adjustment, we're in, at this time, we're in version 24 for CMS HCCs, and FindACode gives us a list of all of the HCCs, even the previous ones for version 21 and stuff. There's also an RX HCC for dialysis status whenever you're coding this, and there is an HHS HCC, meaning the person's on a state federally funded insurance like Medicaid. So that's all tracked, right? But notice I've highlighted the ESRD HCC. We're in version 21 of the end-stage renal disease HCC. And even though it's still a 136, don't let that confuse you and say, oh, well, it's the same thing as the CMS HCC. it actually is a different model. So risk adjustment models have 3 different types. You have the HCC, you have the RxHCC, and you have the ESRD, and that is all for risk adjustment. And then in addition, you have the state, which is the HHS that you may need to be aware of. So why do they have this particular HCC? Because there is a model for tracking, just like it does straight across the board for risk adjustment. End-stage renal disease is one of the diagnoses that if you're not 65, you're not on Medicare, but you have ESRD, then you qualify for Medicare. So as you study and you learn more about how the different payers work, Medicare is the largest payer in the United States, and there's criteria to qualify for Medicare. And one of those is you got to be 65 or older, and then some other stipulations, or have end-stage renal disease, because they track this. And the care for the patient with end-stage renal disease is significant. So what does risk adjustment do? It ultimately allows for a budget for us to track statistically. And that's why there's a specific HCC for tracking end-stage renal disease. And that's why you saw that in the course. The next question was, am I going to be tested on that? No, probably not for the CRC. You won't be tested on end-stage renal disease HCCs unless they ask you a question specifically regarding it. So what you need to know is that it's similar to CMS HCCs. However, it's tracking end-stage renal disease, and it is also another model that's used for that budgeting purposes. I also wanted to pull out some information that I found, and I footnoted these on the answer sheet. So if you're in the CCO club, you can go back and click on these footnotes and read this information for 2020 for ESRD. What were they tracking? They wanted you to know that they were tracking dialysis and functioning graft models for the 2020 end-stage renal disease to calculate the encounter database portion of the risk score. So with risk adjustment, everybody gets a score. You get a score for being male or female, you get a score for your age, and then you get a score for your diagnoses that you have. And the same thing happens with end-stage renal disease. You get a score, and then that score is allows to show statistically how sick that person is and how much money we need to set aside for the future care of that particular patient. Now, the another comment that was in the same PDF regarding the payer year of 2020 for end-stage renal disease model, it went on to also state a few other things that were interesting. And notice the second bullet. It said they were factoring in the coefficients for the dialysis. So if a person's end-stage renal disease, we already know they're on dialysis, right? We established that. And then transplant. So if you get a transplant, you may or may not be taken off of dialysis. And post-grafting beneficiaries. So if they did a graft, did that make a difference? And they also used concurrent Medicaid status. So they're taking the Medicaid status as well as the Medicare status, and they're configuring out with this 2019 model and comparing it to the 2020 model to see if ultimately when it boils down to is, can they learn something? And then they said for 2020, they take a 50% blend of the risk score that was calculated, and they manipulate that and use a PACE organization, which PACE organizations are kind of like an MAO that takes care of risk adjustment. PACE organizations will take care of ESRD patients and tracking and stuff. It's kind of like the power head or the big hat that configures all of this stuff. And then they go in with the data and they come out with the RAPs and the FFSs, which is ultimately a fancy way of saying that we want to make sure that first, that we are establishing the patients at the level of deterioration the end-stage renal disease is causing. We want to know that if they are on dialysis, whether they get a transplant, grafts, or whatever is working to help them. And then statistically, we're going to compare that with all the information that we have and make sure that the patients get the care that they need, and also that we have the money to take care of the patients that we need to. So if you have a patient that's a CKD5 in 18.5, then you know that most likely they're going to turn into an ESRD patient very soon and have to be on dialysis. And so that all ends up being formulated together. Ultimately, that's what you need to know for risk adjustment. Just that it is a separate model, that it isn't something that you normally capture if you're doing risk adjustment. Now, when I did risk adjustment, I did get pulled off. I worked for MAO, and I did get pulled off a few times when it got slow to work with a PACE program that they also worked with and do ESRD tracking. And you're really tracking only one thing, end-stage renal disease, they're on dialysis. What are the comorbidities do they have that is causing problems and such? It's very exciting stuff. But again, you understand the different types of CKD and that it eventually turns into end-stage renal disease, the little break-off point of when it becomes not in 18.5 to in 18.6 end-stage renal disease versus stage 5 is the fact that the patient goes on dialysis. And I did mention, just so you know, just because a person has a kidney transplant and they had been an end-stage renal disease patient does not mean that they no longer are a CKD patient. You could have a kidney transplant and then been an N18.6, and after the transplant, you have enough of kidney function that now you're a CKD3. So you'd be an N18.3. Chances are you're not 100% recovered or won't have CKD after a kidney transplant. You could, but again, it depends. So don't be alarmed if you see a patient that had a kidney transplant and they still have CKD. That is very applicable and possible. All right, that's it. Fun stuff.
Cool. And I had some comments I wanted to share that came in from Dr. Skylar Connell, which was, I'm so happy that they finally broke CKD stage 3 into more clinically accurate categories.
Yeah, A and B. That's right. That happened this year. So that means going forward, that make sure that when you're coding that you understand the documentation, or you're telling your providers, hey, we got to do CKD 3A and B, and it only applies to CKD 3.
And he also mentioned it's important to note that most labs start registering GFR values once they are 60 or below.
Ooh, that's another really, really good point. Yeah.
So thank you for those additions, Dr. Skylar Connell. That was very, very much appreciated.
Lori already said she's enjoying calling him doctor.
Pretty cool.
Because we knew him way back in when he just had his little OBS, right?
So moving on, let me just go ahead and share with you guys that we have a sale going on right now. I still have his comment up here. Let me hide that out. So I just wanted to share that we have a current sale going on at CCO. If you jump over to the link that I'm going to paste actually inside of the chat right now, you'll see we have 30% off our courses and our review blitzes. And those that sale is going to end this Saturday at midnight Eastern. So be sure to take advantage of that, because we do have price increases coming up on January the 5th, 2021. We do have to adjust for price changes in the market, and we also include 2021 updates as well. So keep that in mind. You want to take advantage of the best prices available now. So Alicia, I'm going to go ahead and hide you. I'm going to go ahead and bring on Jennifer, because Jennifer has the next slide that's coming up. She's going to be discussing ERCP and IR same day. Go ahead and take the reins. Thank you so much.
Thank you. That was kind of funny that I had sitting in front of me. I was in the ER a couple weeks ago for a kidney stone, and I have in front of me my lab results, which I have a GFR below 60. So I was like, wow. Then Alicia said it. Your kidneys aren't functioning properly because I have this very large kidney stone sitting in there that's blocking everything. So it's not working properly. And my lovely government insurance, I just finally got my referral 2 weeks later. So I can finally go to the doctor now. Except I just went to Florida and I have to go 14 days without going to the doctor's office. So in December, I'll go to the doctor. But so we had a question come in, and it included a very long operative report. But for ease of time and not having to read an entire op report out for somebody, the main question is, can an ERCP and an IR take place on the same day? So, okay, we love our acronyms, so we need to figure out what does all of that mean. So ERCP, endoscopic retrograde cholangiopancreatography. So say that 5 times fast. So that's why they come up with all of these lovely acronyms. So the endoscopic, of course, you're using a scope to visualize. So being able to see the inside. Retrograde, you're talking about the flow or the movement. Cholangio, that's talking about your bile ducts there. So, and pancreatography is a recording or graph of the pancreas. So being able to visualize the flow from those bile ducts in the pancreas and the liver and seeing if there's a problem somewhere. So that procedure, they typically take a scope, go with your mouth down to your stomach, and then they'll also can insert a tube through that same scope to inject a dye to be able to see everything better, to show up on an x-ray and record those images of the bile ducts. So why would this be performed? So typically if you're having some kind of abnormality that came back from the laboratory or some kind of radiological result indicating a condition with the pancreas, the liver, or those bile ducts that are feeding to the systems. So some signs could be you see a yellowing skin, yellowing eyes, light or dark urine or excretions of kinds, stones, they might find stones, lesions on an organ, perhaps on the liver, or lesions on the pancreas. So something came up abnormal. So now they need to put the scope in and figure out what's going on. Or the ERCP can be performed because there is some kind of blockage, some kind of obstruction in there, and they need to put a stent in there to make it larger to allow that to come out, which is probably what they're going to have to do for me. So I know some people like to see photos, so I found one. So as we are going down for the cameras coming down and looking in through here, now it's going to go into these ducts and figure out exactly if there's a blockage, what's going on. And of course, it starts through the mouth and goes down all the way, feeds snakes all the way down into the stomach, into the duodenum, and looking at those particular areas to see if there's something wrong. When we get to IR, that's interventional radiology. So interventional radiological procedures, they can be used for diagnostic reasons or therapeutic reasons. So they could be treating something, or they could be telling us what's wrong. So they're using image guidance type of procedure for all different kinds of conditions and used on a variety of organs in the body for treatment or to diagnose a condition. So we typically hear of radiology, interventional radiology with cardiology, because, how can we get into the heart to see what's going on or where there's a blockage? So that's very common to hear of interventional radiology when you're talking about cardiology. But you can use interventional radiology also with gastrointestinal, pulmonary, musculoskeletal, GI, GU problems, all different kinds of, pretty much anywhere in the body, you can use an interventional radiological procedure to figure out what's going on. So they do image-guided interventions, work together with other medical teams to provide a concurrent and consistent care for the patient. So typically by providing interventional radiological procedures during a medical procedure, you're minimizing the risk for the patient and potentially coming up with a better outcome for the patient because you're able to see exactly what's going on while they're in there. So they did have a couple images I found. So using interventional radiology, they're able to see a lot of these areas. And of course, one of them is you can see, once they put this tube in place, so they have this stricture here, very coming together. And once they put a stent or a tube in, you can see the difference through that interventional radiological procedure to see what's going on. Much easier using that X-ray for the provider to know what to do. Well, can you code an ERCP and interventional radiology together? So when you're performing them together, a patient is prepped, anesthetized, we all know the beginning of an operative note, the basics of how you prep somebody for surgery. So then your radiologist doing the interventional radiology is going to create access into the biliary tract by a PTC, or a percutaneous hepatic cholangiogram. So percutaneous needle, hepatic liver, so they're going to then inject dye into the liver or the bile ducts and then take x-rays and see what they can see. And then the medical surgeon can perform whatever he needs to do, whatever they find. So typically they might have found, in this case, maybe they found a stone in there. So now they need to do lithotripsy, but we need to make sure that there's nothing else going on in there with that stone. Is the stone the only thing causing the blockage? They can see all that once they get in there. So they do this interventional radiological procedure, and then they can see, okay, there's that stone. Let's perform lithotripsy and see if we've broken it all up and are able to get it out. Pieces might be too large. They might need to go back in and put a stent in or something. So make sure that everything was crushed small enough in the case of a stone to make sure it's able to be easily removed or easily passed. So some things to keep in mind when you're coding for procedures: when multiple providers are involved in the care of a patient, we have to modify that claim so that we know which services go with the correct provider. And I love CMS. CMS has great information. They are my first go-to always because they lay it out so easily, so easy to understand. When you talk about modifier 62, you have your co-surgeon. So 2 or more surgeons with different specialties where the skills of both surgeons are necessary to perform distinct parts of that surgical procedure. So you put a modifier 62 on all the surgeons. They could be submitting the same CPT code or distinct CPT codes, but they're co-surgeons. They need to perform. You could have an orthopedic surgeon and a neurologist, perhaps. You could have working it together. Think about maybe crushed disc after, some kind of skydiving accident or something. They have a lot of nerves in there that they need to work on, but then they also have to repair the discs but they work in tandem and co-surgeon, each doing their portion. You can have a team of surgeons. So a team of surgeons is more than 2 surgeons of different specialties. I usually think of this like separating conjoining twins, something that has a lot of different parts that are taking place. So you have your team of surgeons, and this is more than 2. So you don't just have, one doctor doing the left side and one doing the right side. This is, I can always imagine that operating room as kind of okay, we're done, go, quick getting somebody in and somebody out in the next time. These team of surgeons, so each surgeon is billing for their own procedure with this modifier 66 to indicate that they are a team of surgeons performing this. And typically it goes like a report. It goes by report, not by like individual line. So you kind of have the whole report for the whole procedure. You could have different procedures being done. So surgeons of different specialties, each performing a different procedure, a different CPT code, even if they went in through the same incision. So they're both going in through the same hole, opening, cut, whatever the case may be, depends on, the type of surgery. But they're performing a different type of surgery. And if that's the case, then we don't modify it. So different specialties and different procedures are utilized when they're doing this interventional radiology and ERCP. So each provider is billing for their own service without that modifier for the same patient on the same data service. So, maybe we will work on breaking down that operative report for people to see the difference between the two, but to be able to read an entire operative report in our time frame that we have for this Q&A wasn't able to put that together for everybody. So.
No problem. Thank you so much for that excellent presentation, Jennifer. Next up, I'm going to go ahead and read off one of our reviews. We got some recent reviews in, and I just wanted to share them with you real quick. Janice McCoy wrote, I tried 2 other programs before finding CCO. I failed the first exam I took before finding CCO. I took their course and studied hard this time, along with lots of prayers. I passed the exam. Thank you all at CCO. And we also have one from Joe Ellen Ensley that wrote, thanks to the CCO Blitz and BAT technique, I finally passed. This was my 4th try. I wish I discovered the CCO sooner. The BAT technique has helped me in my daily job as a coder, as well as the CCO club and webinars. Thanks to your website and all your help, I am now a certified professional coder. And congratulations. You probably saw their names earlier on the slides themselves when we actually brought them. So keep in mind that we see that trend a lot where people found other programs and they came to us later on because we helped put the pieces together and deliver the information they needed. That is a common trend that we see quite a bit. So I'm going to go ahead and bring up the next slide. Alicia is going to be taking over the next topic, and it is on lower extremity revascularization. Alicia, the floor is yours.
All right. So the question had come in that this person said, I need help on selective and non-selective identifying the number of vessels that are revascularized. This is just like Jennifer said in her previous one, pretty broad. There's a lot of information here. So I tried to break it up a little bit and give you some resources so that you can take that next step. So the first thing that we need to talk about is, what are we doing with the lower extremities? When we need to revascularize something, then we are going to actually do like a bypass, just like you're doing with the heart. We are going to take the blood flow that is being blocked for whatever reason, whether there's a stricture, there's buildup of plaque, the vessel has worn out, and we're going to bypass it or revascularize it so that it can have more blood flow. And with the legs, it's a little bit different because the body is kind of divided up in, I think of it as, the top half and the bottom half. And they'll say, upper and lower extremities when you're looking up stuff in your manuals. But there's so many areas that we can revascularize in the body. And if interventional radiology is something that you think that you'd like to get more involved with, then you'll be doing this as well as what we just talked about with Jennifer's working with bile ducts and stuff. Any way that you can do, open up or do anything to the tubing of the body. And there's a lot of different lumens or tubes in the body. So with the revascularization of the lower extremities, the blood flow is going down, right? It's got to get to the end, and then it's got to work its way all the way back up to the heart. Whereas with the upper half of the body, we're much closer to the heart, the source, right? Even with the upper extremities, but even the brain, revascularizing that, that's much closer to the heart. But when you get to the lower extremities, that's the farthest point that you could be from that main pump of the heart. And it causes problems to not be able to have proper vascularization. There is a picture here that I got from a great medical journal that kind of shows you a lower extremity, what it looks like. And this is a pedal first, meaning it's going to be down to the foot. Whenever they say pedal, that's what they're talking about. And they're going to do an angiograph, but here we're showing that the blood flow that there's a problem with the blood flow, and there's no blood flow, notice on this slide B, and then C, they can see where it is at, and then D, they go through and show you how they open that up and revascularize, open up the blood flow again. This E is actually off of the iliac, did an iliac angiograph with a 4 French catheter. So anyway, that was kind of interesting. And again, as always, I footnoted so that you can go look at those journals. So there's a couple ways that they revascularize the lower extremities. They can do a leg bypass. So they actually go in and they cut into the groin and they bypass the arteries. And this usually takes 3 to 4 hours to do this. Now, there's another way that they do that, and that's they call it a femoral bypass. Again, they still cut down, they start in the groin, and they take one end of the graft and they attach it to the main artery in your good leg, and then it goes and attaches it to the artery in the bad leg. So what happens when we have this vascularization? This is actually a picture of the first time. We have 5 days prior to revascularization. Notice the large toe, the great toe, actually has an ulcer on it, and there's molting, that purpley coloring. Even look at the varicose veins that are popping through. Just overall poor color to the extremity. And another thing is that even though your toenails are dead tissue, dead cells, they become brittle and flaky, and you end up having problems with them. But you can see how people, without having revascularization of the lower extremities, they can get ulcers and start losing toes and feet from this, and then compound that with other comorbidities like diabetes, which would cause poor circulation as well. It can be a big bag problem really, really fast, I guess is the way you could say it. So this particular study they were talking about something that happens when you revascularize. There's a condition that happens in about 10% of the people prior to revascularization. It's actually extremely painful. So if you know what it feels like to sit cross-legged and you sit on your foot for a long time, and then you realize that your foot went numb, and you know how painful it is when you get those pinpricks and your foot starts to wake back up. That's what happens with this lack of vascularization. It goes dead or numb, and then it's really, really painful. So after they revascularize, there is some swelling and some complications that it can occur due to that. So notice 2 days after the revascularization, this foot actually looks worse, doesn't it? It's got more molten. The ulcer area on the toe to me looks worse, and it's swollen. But what this condition is taken care of, and this inflammation after the revascularization is done, then the 7 days after that, look how much better the foot looks. We have a better coloring. We can see colors that are more natural. There's a little bit of yellow even in there. They go and they debride a little bit on this ulcer, but now it looks like it's healing, right? It doesn't look like death. It looks like the toes are getting good circulation. Even the varicose veins to me look better. And notice the foot overall doesn't have that swelling anymore. Okay, so that's kind of what we're trying to fix. And how do they do that? They do that via the putting a catheter into a major vessel. Now, 2 terms that the person asked about was selective and non-selective. And this is verbiage that you're going to hear when you see when you read these reports. And it's really, really confusing because there's nothing you can really relate or tell a story, how I like to do that, to say that that's what this means. Revascularization. Yeah, we can figure that out. We're going to revascularize. We're going to get blood flow to the extremity again. But what does selective and non-selective mean? Well, the difference between these two terms, and it's very, very important on the process of the revascularization, as well as the coding, to understand. So the difference is that when you do selective, you see selective is the term that's documented, that means that they went into the vessel, but they use some common terms like cannulated, went into, or parked in an artery. And without the documentation or support to code one of the selective catheter placements, then you can't use these codes. And notice 36245, 36246, and 36247, and sometimes 36248. This would be an example of revascularization of a lower extremity. This came from AHEMA, which is fantastic with this type of learning documentation. They're one of the leaders, I think, in educating for documentation and procedures in-house. So that's an example they talked about, is you're going to see verbiage like cannulated, went into, or parked. Now, it also means, though, that they inserted a catheter into the aorta. Okay, when you do that, it's considered non-selective. So selective, they went into. Cannulated just means that they're putting the tube or the catheter in, went into or parked, and non-selective means that they went into the aorta and they entered the aorta, but it's considered a non-selective vessel because they only went into the aorta. Now, I'm going to skip down to this other area that to me really explained it well, because I thought, okay, AHEMA does great. But then I found this difference between selective and non-selective catheterizations for diagnostic studies. And I thought, okay, they explained it even better. So whenever you do selective or non-selective, what you're looking for is that non-selective catheterization is a procedure that involves inserting the catheter, we've already established that, into the femoral artery, because we're doing an artery, and threading the catheter up and into the aortic arch. Now, this is going more towards not working with lower extremities because we're up in the aortic arch, whereas before they were talking about lower extremities, and so again we were talking femoral. So just that caveat there. If you're going into the aortic arch, you're probably not revascularizing the lower extremities. But don't worry, it goes on to say that after the catheter is placed in the aortic arch, so that's that big giant vessel at the top of the heart, they put fluid in, and then the difference between non-selective catheterization and selective is that non-selective catheter is only inserted into one vessel, the aorta, and remains there. Okay, so the same thing happens when you're doing it into the femoral. It goes into the femoral and it stays there. Okay, that non-selective is staying there, whereas selective, you're going to keep going. That's the key. That's what you have to remember. So if you have selective catheterization procedures, then what you're going to do is you're going to go into the aorta or the femoral, whichever major artery you tap into. And then the selective catheter codes will describe each additional vessel that you go into. So you can have multiple codes as you break out into those branches of the additional vessels. Okay, and that was the second part of the question. How do I do that? So I've got some examples here. If we're going to do lower extremities, there's 3 territories. That's the way they divide it up into. And I like to think of interventional radiology when we're talking about vessels, whether they're in the chest and the head or in the lower extremities. I like to think of them as like rivers and creeks, right? So if you know, if I grew up in Missouri, we had the Missouri River on one side of the state, and we had the Mississippi River on the other side of the state. And then I was able to say, these are major thoroughfares. These would be what we would think of as the arteries. And then those major rivers would break down into smaller rivers, and then they would end up being creek systems, right? And then each time it broke down into another division, then that would be like a branch or territory. So 3 territories. The first for lower extremities is you're going to see that we have the iliac. The iliac. So think of the bones. The iliac crest is the top of the pelvis. And that's how you can tell if a skeleton is a male or a female skeleton, because it's real heart-shaped if it is a male, but it's much broader and more, and it kind of lays back on a female. And I think that's where they get birthing hips. So the first territory would be the iliac, and it would have the common iliac, internal and external iliac arteries, all based on that bone, right? The name of the bone. So that tells you where it's at. The second territory is going to be called the fem pop, or the femoral popliteal. And so we have now the common femoral, we have the profunda femoral, superficial femoral, and popliteal arteries. So we're now branching off, right? We're going down into the lower extremities. And then the third territory is going to be the tibial perineal. And so that's going to do anterior tibia, posterior tibia, and perineal arteries that go down to the lower part of the lower extremities. Now, I mentioned earlier that we got to see the bat technique, and this is our little logo for the bat technique. These came straight from FindACode. What I did was I just literally copied and pasted the codes that were mentioned earlier, and we're going to talk about the differences. When you do the bat technique, one of the things that you do is that you bubble in an area. So this would all be bubbled together, these codes. And in your manual, they would be in a list. So you would bubble around them. Okay, so these all get grouped together. What separates each of these codes? We're going to highlight everything after the semicolon, but there's certain areas that we might want to underline and highlight. The first thing is 36245. This is a selective catheter placement, right? That's important for us to know. And we, of course, are going into our arterial system. But notice after the semicolon, it says each first order abdominal, pelvic, or lower extremity artery branch within a vascular family. So this is our starting point. And then the 36246, what differentiates it from 245? It looks like it's the same code, except for after the semicolon, we notice it says initial second order. So we have our first order, and it tells which vessels it could go into. And then we have the initial second order. So we're going to use both of these codes if we keep going, right? And then if we keep going further, then we have 36247, which is the initial third. Remember, up here we have 3 territories for the extremities. And then it tells us we had each first was underlined, initial second, initial third order. And it says it's more selective abdominal. It lists them, lower extremity, artery branch, etc. And then in addition, like an add-on code, we have additional second order. If we're going to keep going, then we have 36248. And all of this information is underlined. Additional second order, third order, and beyond abdominal, pelvic, and lower extremity branch. But you go ahead and highlight the rest of that, because you're going to list in addition to code for initial, second, or third order vessel. That's how you distinguish between which code to use, which one not to use, and how many you can use by what the documentation tells you. So if they tell you that they went to the initial third and they went to the, pelvic artery, then you know you've got 36245, 36246, and 36247 that you're going to be able to use. And when this is bubble and highlighted all together, you know that these 3 orders all go together for cath placement, selective cath placement. And then on top of that, you know that I've underlined that each first order, initial second, initial third, and then we have the 8 code that if we have to keep going that we can additionally use. That's the BAT technique. It's so easy and it will make you faster and more accurate. Now, just to wrap up here, that I went ahead and highlighted what the particular article had said about coding those codes for the lower extremity. There's a lot of other different codes. This is one I picked to show as an example. So don't think that 36245 is the only code that you use. No, it depends which vascular family you tap into for the lower extremity, you know, so on. But note here, it also said that if any non-selective code, such as 36200, first order, and then it goes on to say, these are bundled into 36247 on the accipolateral side, same side as the catheter placement. So notice that there's a lot of bundling done when you're doing interventional radiology. In other words, if you go so far or something, then they bundle in some of that work that was done. Now, I was going to keep up on my computer Z Health's, one of their interventional radiology coding manuals that I have access to via FindACode, because you can get them online now via FindACode. So I have my one that I've shown when I've done, you know, lectures or we've done webinars before, and I love it. And I've got little sticky notes and notes written all over it. But now you can actually get an online copy via FindACode. And there was a great appendix that I noted, and I was going to show it to you, but my bandwidth really wasn't holding up with keeping that up on the screen. So you can go to findacode.com library and then look for Z Health, and you can purchase the online copy of that actual text. And you can get the Appendix A, which shows you procedures that must be performed selectively, and then it had all of the codes that would be used for selective. And I thought that was really fascinating, because we know that if you're going to get into interventional radiology, Z Health is actually the leader. And if you want a discount on think that, you know, it would be beneficial to you to use an online version of those manuals, then, you know, this is the way to go. Go to FindACode and check that out. So I hope that answered the question for our person. It's really hard not to go off on a tangent, because there is so much you could talk about regarding lower extremity revascularization. It's pretty intense and fun.
Thank you for the great presentation, Alicia. I'm going to bring up the next slide real quick, which is our final poll. Our final poll is, are you a member of the CCO Club? That's a pretty simple one there. Let me go ahead and paste it into the chat, the link for that poll, so you guys can answer. This is our last poll, so pretty soon I'll be showing you the answers to all the previous polls as well as this one. And to present our last topic, I'm going to go ahead and remove you now, Alicia, and I'm going to go ahead and bring in Jennifer. The last topic that's going to be discussed, sorry, the second to last topic is hospice codes in the nursing home, and you have the floor.
Thank you. I'm going to go through this rather quickly, because it seems to be a easy question to answer. So what CPT code would we use for a patient in a nursing home for the provider to bill, adding the patients to hospice care? So they're using G0182, and it's denied by Medicare for the POS, or place of service. So of course, Medicare is my go-to thing, and they have some wonderful toolkits and brochures about this that I have included some of the links. So a patient in hospice is somebody who's defined as having a terminal illness and a life expectancy of 6 months or less. So then they're put into a hospice care. So CMS has some information about hospice. Typically, people you see in hospice typically are on Medicare. They're typically older or have a disability that perhaps allowed them to have Medicare coverage. So Medicare is, of course, a good spot to find this information. So a patient has the option to elect to have hospice benefits instead of Medicare. So it's kind of like a group payment, and all of their services. It's covered at a better benefit for the patient because sometimes hospice care can require a lot of medications, pain, cancer medications, kind of whatever is necessary, which could be very expensive. So having it under the hospice benefit, it's a benefit to the patient because they don't pay that 20% portion that they normally would under standard Medicare. But there are some downfalls about it as well. So, and they have to opt to have it. So you fill out a form and send it in and, opt to use hospice care. So in that instance, the care is provided by a Medicare certified hospice organization, and they cover under this provision. So patients can voluntarily terminate this with their benefits. They have some time periods that they are able to use these benefits. So almost like skilled nursing facility, if you know anything about how Medicare runs with skilled nursing benefits, there's a time allotment allowed. So hospice care includes a package of items. So when you say they're in hospice and elect for this hospice care, they're provided to these terminally ill individuals. There's a written care plan that's brought up by their rendering provider and is periodically reviewed by that attending physician, very important terminology, and by the medical director. So the medical director is that hospice coverage medical director of that hospice allowed, Medicare allowed hospice facility. So that's going to include their nursing care, physical, occupational, and speech therapy services, social services, because the family may need social services, the patient may need those social counseling types of services to provide grief or other, how do we deal with these problems. Services of a home health aide and homemaker, so somebody to come in and help. Medical supplies, drugs, and biologicals, which could be a very large benefit for some of these people. Your physician services, short-term inpatient care, so no longer than 5 days, and on an intermittent, non-routine, occasional basis. So short inpatient care stays, counseling, and other services that are offered. But for payment of these services, they have to file that notice of election that they want to be in hospice care. The service has to be rendered by that attending physician. So a very important key part there. The service by an employee of the hospice organization as well. So your home health, your nursing, they're employed by the hospice. Payment for the physician services along with routine home care, continuous home care, inpatient respite care, and general inpatient care. Those are the 4 levels of care that are allowed under Medicare hospice. So the inpatient respite care will pay for those 5 days. Subsequent days are paid at a home care rate. So they're paid as if the patient was at home. So those payments are for the care provided for Medicare or Medicaid certified hospitals, skilled nursing facilities, hospice facilities, and nursing facilities. The general inpatient care does allow for payment at an inpatient rate when the general inpatient care is provided at a Medicare certified hospice facility, hospital, or skilled nursing facility. So for a nursing home visit, Medicare stated that if a hospice patient is receiving routine home care while residing in a nursing home, the hospice has to record visits of all of those physicians and social workers and everybody that's helping the patient for their palliative care and any related conditions they have. In this example, the nursing home is acting as the patient's home. It specifically says that in their manual. Only the patient care provided by hospice staff will constitute a visit. Medicare rules for the hospice care, they're outlined in their chapter. They have a specific hospice chapter in their internet-only manual, the IOM, which it's very easy to search out, 100-04. Google that, you'll get it. It's also located in your manuals. So some of the information of the Medicare manual is in your manuals. Now the G0182 is the code that they inquired about. So that's physician supervision of a patient under hospice. Patient's not present. They're doing reports, review of laboratory, communicating with people, 30 minutes or more within a calendar month. So some very important terms are posted in there. What are some reasons that these codes can be denied for hospice care? That place of service indicator. So there's specific place of services. So if it's a nursing home and we're using the nursing home place of service, but it's acting as the patient's home, you could have the wrong place of service in there, because if it's acting as the patient's home, then that's what you want to reflect. The physician, maybe they're not listed as the attending physician or the medical director, because they only pay the attending physician and the medical director. It's not, they didn't file an intent with Medicare that they wanted hospice care. So now you're billing a hospice code and they have standard Medicare. That could be a possibility. The time limit has exceeded for their hospice services because they're within a time frame that they provide these services. They require certain modifiers if it's billed by the attending physician or if it's unrelated to their care. I recall one time a patient came in to be seen in the orthopedic clinic and we billed the services and it was denied, saying they're in hospice because we're not the hospice doctor. Well, we also didn't include a modifier because they were being treated for an orthopedic issue that had nothing to do with their hospice illness. So frequency, they're submitted on a monthly basis. So there's a time frame listed in their toolkit that says when you file these claims. Perhaps it wasn't filed within that calendar month or whatever. Some more information I found says that these specific codes, 0179, 80, 81, and 82, are not covered for patients in skilled nursing facilities or other nursing facilities. The question stated we build G0182 in a nursing home. It's not allowed in those facilities, only hospice and home health. So now we have to go back and either review that medical documentation and say what other service is it counted as for a nursing home, or look at one of those options. Did it have the wrong place of service? Did it have not the attending physician? Any of those other possible denials, it would take some investigative work to figure out. MAC carriers could possibly have a few adjustments than CMS. CGS, which is for Kentucky and Ohio, they have specifically information on their website it's called Care Plan Oversight Services when you're dealing with hospice. So the local MAC carrier may have some more guidance as well. Typically, rules are from patients with Medicare Part C, which is your Medicare Advantage plans like Aetna Medicare, Humana Medicare. Typically, they're supposed to offer all the options that Medicare does. That's standard Medicare, however. So beginning in January of 2021, Medicare Advantage plans can choose to include a hospice package in their benefits because that's not standard Medicare benefits. That's something different. They opting for hospice coverage, which may include some services and does not include other services. So beginning of January, other plans may choose to offer hospice package services. And then we definitely need to pay attention to what their rules are for their hospice services. Again, there is a hospice toolkit offered by CMS, which has some great information in there as well. So definitely, if you're in the hospice field, you should know these books by heart because you're going to get a lot of your information that's needed to bill for these very important, very necessary services for these patients is all going to be outlaid in their directions and in their information.
Great stuff, Jennifer. Thank you so much. Mm-hmm. And I am going to bring up the next slide, which I think you guys have been waiting for. And I think it's kind of a big deal. So let's go ahead and show that. This is the new contest. All right, and I'm bringing everybody on board now so we can talk about this one. This contest is brand new, and you need to go to the link that I am now pasting into the chat. I'm going to go ahead and open up this link to responses and go to www.cco.us/contest and sign up on that form in order to be qualified to enter for a chance to win either a Review Blitz package, 1 year of CCO Club Basic, or a 1-hour coaching call with Alicia. Okay.
I saw Sandra Garza said, "Thanks, good to know I'm billing them correctly." Jennifer.
It's always nice, yes.
Yeah, it's like, hey.
All right, we are going to go ahead and bring up our last topic, and this is going to be Alicia, so I'm going to go ahead.
Okay. The question came in, said, when a coding clinic clarification comes out, when would that take effect? With the effect date, or would it go back to previous times as well as when ICD-10-CM was already in use? I'm confused on coding clinic guidelines in this sense. So what I did was I went ahead and kind of said, let's introduce what coding clinic is. It won't take long if you're in the medical coding and billing arena before you realize what coding clinic is. It is ultimately the expert that we go to. It's put out by the AHA, and it's an advisor. They started back in 1984, and they take a group of experts and make decisions about it. Ultimately, when you break everything down, both in ICD-10-CM and also now for PCS. The key is that when it goes into effect is when the publish date is. So it's very important to pay attention to the publish date. And I went directly to the coding clinic website to be able to give you the information. There's also some other things that Coding Clinic provides. They are the official for ICD-10-CM and PCS coding advice and guidelines. They answer questions that come in about sequencing and which codes to use. They also serve as reference points so that you can use them as reference for regulatory and other requirements of reporting for diagnostic and professional information for medical records. So again, they are the experts, and they do topic requests, and they do articles specifically about practical information that's going to be applicable to scenarios that you come into as you get into your career. So I went ahead and just picked out a diagnosis that I knew would have questions about it. And this comes out every month. The code that I picked out was Parkinson's disease, because I remember there was some questions about, okay, what's the difference between coding for Parkinson's disease and Parkinsonism, which is a little bit different. So the code for Parkinson's disease is G20, and I just pulled this from FindACode. It tells you all of these are the information that also means G20, just like your regular encoder. It said also you want to make sure that if you're going to code G20, that you let them know if there's any behavioral disturbances, and note that it excludes dementia with Parkinsonism, which is actually G31.83. So FindACode, I get Coding Clinic via FindACode. Now you can get it separately on its own and pay for it, or you can have it bundled in with FindACode, or maybe with your encoder, depending if they offer it. And so it just works out great for mine to be a package deal. And so I went, and sure enough, it's like, yep, I thought there would be something on G20, and there was. And so the date that it came up was 2017. And a question came in that said, ask the editor, Parkinson's dementia versus Parkinsonism. And this is where this excludes. So in other words, somebody needs clarification on how to code that. And so the question is given, and the question is a scenario or something that's been submitted by a person asking, and I don't know how they pick the questions. I don't know. I'm sure that it gets questions get asked repeatedly. So, and I don't know if you get anything for having your question picked. I don't know, as a talking point. But ultimately, I'm not going to read this because we're a little short of time, but the question at the end ultimately is what is the appropriate code assignment for Parkinson's dementia with aggressive behavior? So thinking, is it G20 or is it this G31.83? And then they give an answer. Okay. So the answer isn't just code it this way. No, they divide it up. So it's divided up kind of in 3 parts, which I really appreciate. Again, it goes back to education. They're going to answer the question. They're going to give you a little bit of background about the disease process, and then they're going to clarify anything. And I went ahead and color coded that so you can see how it's done. And it ultimately tells you, when they set up the scenario and they ask the question, how do we code this? They say you're going to assign G20 for the Parkinson's disease. And in addition, you're going to code the FO2.81, which is dementia, and that a specific dementia with diseases classified elsewhere for Parkinson's dementia with aggressive behavior. So that's the answer. They're telling you we're the expert and this is the way you need to code it. Then it goes in to say, this is what Parkinson's disease is and how it is affects the body. And then it goes to further clarify what Parkinsonism refers to the symptoms of Parkinson's disease. Therefore, that's why it looks different or gets confusing. So it's like a 3-part answer. And they do that every time, and they do it very nicely and concisely. You can appreciate the way they do that. So to get more information about that particular question, and if you ever want to use it or cite it as a reference, say you need to let a provider know how to code it if they are questioning which code is the proper code, then you can say, okay, I can footnote this. It came out in Ask the Editor in the 2017 issue 2, and you can give them a link. And it was the American Hospital Association that put out coding clinics. So all of this stuff is always attributed to where they can reference it so you can cite your work. But of course, I pulled this off FindACode, so it has a FindACode link directly to that so that I can also use, in addition, if I needed to cite the question. And I use this all the time when answering questions that students come to the club with, as well as other people that ask questions about, I need clarification. It looks like I should code it this way, but I'm not really sure. It's really exciting, and I urge you to look into it. However, know that it is very, what would be a nice way to say it costs a lot? You're going to want to budget for it, put it that way. It is definitely an investment, and a lot of times your employer will pay for it. They'll bundle it in with maybe your encoder. Like I said, FindACode has it. You do pay more for that, but it's absolutely worth it to be able to just bring up the code and then go straight down to coding clinic and say, let's see if they said anything.
Excellent.
And sometimes there can be more than one statement or information attributed to a code. Do we have a winner?
You know what? I got something first. Okay. And the first thing I got are the answers to all the polls from tonight.
That'll be
which
fun.
Everyone's been waiting for. But I do have to let everybody know that the contest is closing as soon as I'm done showing these polls. And I'm gonna announce the live winner using a brand new tool that's really cool, which Alicia told me about. So let's go ahead and bring up all the polls. Everybody's here on screen. Give me 1 second so I can drag these over onto the screen here so you can see them. The first question to the first poll was, how many times have you attended a CCO Club webinar? And the answers were first time with 29%, 2 to 10 times with 35%, hundreds was 0, and I'm committed with 35%. So those are the answers to the first poll. I think I might have gotten the third one wrong. Hundreds might have we? All right.
They're
So
stacking the poll.
that was the first answer. The second poll here was, what is your status in the medical business related job world? And the answers to that was, we have an 8.33% with looking at medical coding as a career. 41% was certified and looking for a job. 50% is improve my current job situation and earn a new credential. And nobody is not pursuing employment at this time.
That's good.
So that's good. And then we have our third poll, which is, what is your medical background? And the answers for that one is 9% for clinician, 61% for a coder, biller, or risk adjuster, 14% for management, and 14% for none of those, which means you might be pursuing your credential possibly, or moving to look into the field.
You can put it in the chat. Let us know.
And then, put it in the chat. Let us know what that none means. We're curious to know. And then we have our last poll, the fourth one. Are you a CCO club member? And the answers to that one are yes, 76%. Fantastic.
Oh my word!
And 25% with a no, and 0% with what's the CCO club? Is it important for my career? So
that's the most we've ever had, I think, of club members on a webinar.
Sounds like a lot, yeah.
Yes, it is. So
fabulous.
Now comes the fun part, and I've even made a fun slide for that. This is the live drawing for the chance to win either a Review Blitz package, 1 year of CCO Club Basic, or 1 hour coaching call with Alicia. So give me 1 second here. I am getting this
Jennifer Jovelette Williams, she's the one that used this at a conference, a remote conference that I got to speak at for north part of Texas, and it was so much fun. It's like, oh my gosh, this works out great. And so I'm glad Jesus was able to grab this. And a special shout out to her for.
All right, so here we are. This is called the Wheel of Names, all right? And this thing has all the names from all the people who've entered the contest. And I'm about to spin this, and it's going to show us the winner. Okay, so here we go.
Oh, we should have had it needs a sound
Vanna,
effect.
here. No, wrong side. Here we
go. Yeah, it needs Vanna.
Wrong side.
No. Janet. Is it stopping?
Oh no.
It did.
Yeah.
Janet Claire Ricketts. It even tells you, look at it. Yay, Janet!
Very good, very good.
Congratulations.
That's our winner. Janet Claire Ricketts is the winner. Now, in order to claim your prize, please contact and open up a ticket at helpdesk.cco.us so we can go ahead and log that win. So the winner, I'm just going to put this in the chat real quick so everybody could see, is Janet Claire Ricketts. Congratulations. All right. Now, we are going to move on now into the, let me close out this window, into the questions from the chat that we have been kind of getting throughout the night. If you still have questions, you can ask them and we'll take a look through them. I'm just going to scroll through here and kind of take a look and see what I can spot. Give me 1 second while I go ahead and...
I'm going to move my screen so I don't have to look up.
All right. So let's scroll up and come on down and see what we have. I'm not sure if this one is possible to be answered right now on the event, but let's take a look at it real quick.
I love to research. So okay.
And it's, can you give some examples of covered diagnoses for billing 99497 advanced care planning? Usually the physician charges this, and when they have a family meeting and decide to change the patient to DNR.
Mm-hmm.
Is that a tough one, or do you think we can answer that one real quick?
I've been looking it up. So I've been doing a little bit of research. So what I have found is that actually one thing I found here, I'm trying to go back and look at it again, says it actually does not require a diagnosis. Of course, we have to put diagnoses with everything, but it doesn't require to have a diagnosis. So it's nothing specific. It's nothing that has to say, that they have terminal cancer or, heart attack or, anything like that. So it does say some documentation requirements were, a brief summary because it's a voluntary conversation. Very important. It says that many times that it must be voluntary. You document your start-stop times. So something else very important that a lot of times doesn't happen in these specific codes that require start-stop times. It says no diagnosis requirement. So there's nothing specific that has to be required. It does say for documentation, however, if a serious illness is featured in the documentation, it should be reported on the claim. So just make sure that if you have that serious illness in the documentation, that it's also on the claim. So what should be included in that record is who's involved, who are the clinicians involved, who's involved for the family, the patient, caregivers, who's there, where this took place. If you completed documents, you don't have to complete documents in order to bill one of these codes. Any decisions made and the time spent. It is a 30-minute code with a 16-minute threshold, minimum threshold. So you have to spend at least 16 minutes in the care and discussion of advanced care planning in order to use the code. So.
Oh, that's a good one. Skylar put in Z66 DNR status.
Oh, yeah.
Given the fact that they've discussed that on the counter. That's a good one.
Yeah. So, I mean, they could talk about all sorts of things, the prognosis, palliative directions, hospice, changing their mind, who can help. There's lots of different recommendations. So.
Okay. And we had another question come in, which we get a lot, and I wanted to cover this also, which is, will the new 2020 E&M coding changes be reviewed soon, or have I missed it? And you have not missed it. We actually have a professional certified coder that we referenced to, Maggie Mack, for the E&M presentations, and we reached out to her actually about a month ago to ask her, can we get you on board to make a recording for the club members and for the students? And she actually said she's holding off because she's waiting for the final rule. She's seen a lot of conflicting information coming out from different sources, and she wants to wait until the final rule is in place to make that presentation. As soon as that is in place, and as soon as we know it's good to go, we'll bring her on board and record that presentation and have it ready for everybody. So I'm glad you asked that question, because it is a very popular one that we had to kind of address at some point.
And we're getting, like he said, a really good expert.
I just wanted to throw a shout out to Whitney Holt. She said this is new format, and we love it. We think it's great too.
It's going to be fun.
Yeah, we've had so many comments come in, and it's been so nice to see all the comments and engagement from the community. It's harder to see that inside of GoToWebinar, at least publicly on Facebook and YouTube. So it's been a great change to kind of see that. And more praise coming from Diane Stewart, encouraging Dr. C. Alicia's presentation on cloning clinics was enlightening. And yeah, so that kind of covers it. I don't see any other questions inside of the chat to kind of bring up there. So let me just go ahead and share my screen again, and let's jump on over. Alicia, did you want to talk real quick about remote presentations?
Yes. Before pre-COVID, then we were doing a lot of local presentations. We were going out if they were close to us, both Jennifer and I. But you know what? COVID didn't really slow us down, because we were able to do remote. And now that some of the chapters are able to do remote presentations, we've been doing those for the chapters. If you need more information, check with your chapter officer to see about how you could have us come in and do a remote presentation for you. These are a few of the topics that we've done in the past that are very, very popular, but we do have some others in the background that you might be interested in. Again, it's really easy, though, to book us. What you would just do is go to cco.us/remote-presentations and look and see what we have to offer, see if our dates are open. And Lori usually handles this, and there's a little bit of paperwork to fill out, question-wise on a questionnaire, so that we can make sure that we meet the needs for you.
Absolutely. And while you're at it, while you're on the website, also be sure to check out the CCO Club because we will have transcripts and replays and slide decks and the answer sheets that somebody was asking about inside of the CCO Club for this entire presentation in there.
So all those footnotes and all those links, CCO Club members get all that.
Yep. If you haven't yet, we have a Facebook page, facebook.com/cco.us. Like us and follow us. Following is important so you get notified every time we go live, and share everything you see, everything there that can be shared. Share it with your friends. Let them know. We value the sharing. The sharing is very helpful.
Yeah.
And then YouTube, we also have a very dynamic YouTube page. We are probably the largest page. I think we are the largest page in this entire niche. We have 4.1 million views lifetime on YouTube. We have 33,000 subscribers and over 1,000 free videos available for you to research and look up.
So everybody stop right now and press like on YouTube. Isn't that what it with the little the thumbs
bell.
up? Yeah, hit the thumbs up right now, and watching the number will go.
And subscribing on YouTube will also get you notified when we go live on YouTube. So if you prefer one platform to the other, then subscribing on that platform is going to help you get that. And
you can share both platforms, right? You can you know say, hey, they did this webinar, and if you think this is something that someone you know would be interested in, just send it to them, because I send my family YouTube videos all the time.
Yeah, pull up the YouTube video of an old coding thing and share it on Facebook, and that way you've
there you go. You can share it on LinkedIn too.
Yeah.
Definitely. And we have, we'd like to know what you think about the survey. So we have a survey up. Just go to cco.pe/QA 2020-11. That's 2020 for the year, 11 for this month. And let us know what you thought about this presentation. Did you like it better? Did you like it less? Is there something that's missing that you wish was back? Did you not like the polls? Like, let us know. And we really read this stuff and use it to improve the presentations. Here is a list of all the links that will be part of the slide deck inside of the CCO Club. But in case you want to jot it down or take a quick screenshot, there's all the links that we've mentioned throughout the event tonight. And that leads us to our last slide. Thank you so much for attending this event. This is our last event for the year. We don't do one in December. So we want to wish you guys a happy holidays, a happy new year. And we're going to be seeing you again in January.
Yep. Make sure you send in those topic requests so we can do our research.
Thank you so much for attending. Thank you, Sylvia, Lori in the background. You've been answering questions and helping out so much. Alicia, Jennifer, fantastic presentations. To everyone that's visited, to the members, and to all the attendees, thanks for giving us your time. We went over a little bit by half an hour. We're sorry about that one.
First time, new format.
But don't worry, next time will be much better. And we appreciate all the time you spent with us tonight. Have a good night.
Bye, guys.
Bye.